couple of other quick thank yous that I don't want to forget. Robert Mansfield from IGHS has been super helpful in pulling this together. And Devin McCabe, who's not here but has organized this for past years, found time in her new job to help and to guide me through various things. So thank you to both of them. All right, I think we're ready for our first panel. Eric and Elliot will come up. And I think I'm going to, we were talking about who should go first, and I think I'm going to start with Dr. Goosby. Eric Goosby is a global health leader of stunning renown. Has those words been used? They should be. Yeah. Eric trained in these parts, went on to take various federal government roles, culminating in the head of the PEPFAR program, U.S. AIDS Ambassador, which you did for how many years, Eric? 5 years. Oversaw a tremendous transformation into a far more efficient and effective program during that time. Remarkable. And as a result, was tapped for another big job, the Global TB Ambassador, a stint of also about 3 years?
We're in our fourth.
Fourth year, and big report just came out, and I'm sure you won't relax, but I hope you do take a little time after that incredible accomplishment. Eric's going to talk to us about global health diplomacy. This is a concept which is critical to achieving the vision of Global Health 2035 and of the Sustainable Development Goals. I'm not going to tell you any more than that because Eric will. Thank you.
Well, thank you so much. It's an honor, and it's very gratifying to be asked to speak briefly to this particular group specifically. It is very clear to those who are involved in making impossible decisions about who will benefit from a resource allocation and for how long, without the information and tools that many people in this room have dedicated your professional lives to creating, and have done so in a way of high integrity. Those decisions that are made reverberate in individuals and in their families and in the people dependent on them in ways that continue for many years. And those of you who are old enough to have witnessed the results of your decisions understand the truth in that statement. But I begin this discussion to just remind us that this is about the real thing. This is about defining service portfolios that have variable ability to penetrate the populations, all of whom need those services. And very much of our understanding of what to prioritize and when and how to deploy it are dependent on modeling and guesstimates, estimates, and observations that further validate that decision in as close to real time as you can make it. Not that you know instantly you're right or wrong, but you should position your surveillance systems so you continue to reap data that tells you you are right or wrong within a year or 2 years. I think that it's your work that populates that discussion, and again, the accuracy of your work and the intellectual honesty that goes into it and that's reflected in talking about it becomes the context in which policymakers who venture into your work to help make decisions use. And I just want to tell you it's deeply appreciated, but I want to tell you more importantly, it's desperately needed. As we understand how the disparities that are on this planet impact the outcomes that we all are looking at so vigilantly, to me, it gets down to understanding and measuring repeatedly what the outcome is for which population and how it changes over time, and how that information needs to feed back in to prioritization of unmet need and ultimately to the next allocation decision in a budget. So I think that the idea of global health really focuses on those kind of multiplicity of areas of activity that cross disciplines and cross sectors of government, cross sectors of society. And the only unifying elements that kind of are in some way, sometimes tangential, sometimes directly, asked to take those issues into account, process them, and to come back with the decision are in the realm of policy and politics. And that for you to ignore that is ignoring the means through which your work is going to move to inform, influence, and change programmatic decisions. Because that really is the ultimate point, that you get up and do it every day. And if your work is not informing or altering the thinking and ultimately those final decisions, you need to figure out ways to make sure that your work is better positioned in that continuum of idea to policy allocation decision. Global health diplomacy enabled individuals in government to start conversations that normal diplomacy without a health theme does not. The ability for a country to engage in a conversation with another country around a disease process, the benefit of a prevention effort, a treatment effort, to look at the change in population outcomes as you introduce a new diagnostic or new treatment modality, and appreciate in your surveillance how it does not uniformly, homogeneously distribute across the population. That should be in the planner's mind before they implement a program, but often isn't, but at a minimum needs to come in later. I will just say that President Obama and Secretary Clinton saw the unusual role that PEPFAR played in facilitating dialogue with those same countries on other more difficult issues. Uganda, all of the issues, all of the countries in and around Lake Victoria had, as we moved with taking the treatment modalities for HIV to scale in Uganda, the United States became the major funder of care and services for HIV for their population. It dwarfed the regular budget for Uganda for all other diseases, but gave Uganda an infrastructure on which other disease services could be placed, and through an integrated model delivered to those same patients with HIV, but also diabetes, hypertension, and coronary artery disease became a possibility. The attacks that the legislature in Uganda put forward on LGBTQ activity was vicious, and it was entirely through our relationship at that time, 10 years long, with Museveni, that he knew that the United States had already made a huge investment in his people, and our unhappiness and the unacceptability of our criticism toward the laws that were being passed against homosexuality were unacceptable to us. And although we never threatened to withdraw services, the fact that we had that long demonstrated commitment to Ugandan people, he sat down and spoke to us a dozen times about this, and we strategized together about using constitutional rules to table remove legislative proposals that were unacceptable, and were able to do that. And stretch out, and introduce a process that allowed for a different dialogue understanding to at least be part of the discussion. They still are stalling in that discussion. It still flares periodically since then, but it has stayed off as a law. And that's, I just give as an example of how that investment in time and people in a country changes the way that your interest in talking about something that is not comfortable to the leadership will allow you to move forward with it. I think that that is an example of how global health diplomacy can be effective. It's also an example of how state departments or equivalents in countries really do have a opportunity to enhance how their country relates to another country, either concomitant with or apart from the diplomatic discourse, to go ahead and engage in problems, defining problems, and then working together on solutions that have at the outset the mutual understanding that there will be a shared responsibility in the resources invested, in the services developed, that will continue to come from that donor country, but that the relationship with the country shifts from donor to donor recipient to one of a partnership, and facilitates, again, an enhanced relationship between governments, and if governments are willing, allow for a infusion of technical assistance and talent that specifically reaches the civil society segments of that community, which become the basis on which a constituency develops and a ongoing dialogue for sustained responses begins. In Uganda, the difference between HIV and tuberculosis is an example of one with a constituency and one without one, and how those service specifics expand or recede over a period of time. Tuberculosis in Uganda, in all countries for the most part, has been there for 50 years. It's a line item in their budgets. They don't argue each year for new money for TB. They just roll the money over from the year before. The money investment is not related or associated with understanding how it does or doesn't buy outcomes. That kind of rigor in budget making, strategic planning has not occurred in TB almost at all. And I again, just give that as an example of these huge differences in the same Ministry of Health with the same epi group, the same Minister of Health, the same president, having very different outcomes. So I think I will just kind of shift into talking about the extraordinary convergence of many streams of that I think challenge our ability to stand up medical delivery systems in countries that are most heavily burdened. The belief that throwing large resources at a problem that evolved out of our Global Fund and PEPFAR experiences coming out of 2002, 2003, Gavi and coming in, Unitaid coming in later in 2006, all of these kind of alternate motors of resources, specifically targeting either disease processes or populations, have become a big part of the multinational and international expectation for mounting large responses. The world realized that throwing large amounts of resources at a problem could actually be effective. I think HIV, malaria are examples of that in many settings. TB is too, but to a lesser degree. But I think the belief and expectation began to shift in the way people talked about festering problems and the response to them. I think that it is your work that is going to inform our ability to shift into budgetary development that allows for us to be buying outcomes specifically, at least to understand what we believe we're doing with this investment in this area for these things will impact this population on these outcomes that we're basically trying to expand and move to scale in the country. I think getting and understanding budgetary development, strategic planning, and how that informs unmet need, prioritization, and the final allocation decision is the continuum that we're on as we pivot into universal health coverage. So I will stop with that. Sorry.
I'm very glad to be here, but I will say I've got a little bit of an attack of imposter syndrome being on a panel with Eric Goosby, but I will try to soldier on. So, equity or efficiency, equity and efficiency, these are perhaps the two most important criteria that health policy researchers and decision makers consider when thinking about designing a portfolio for global health interventions and a portfolio of interventions for universal healthcare programs. So, what do some of the leading lights in our profession have to say about this? Paul Farmer says, efficiency cannot trump equity in the field of health and human rights, whereas Gro Harlem Brundtland, the former Secretary General of WHO, says the most cost-effective services should be provided first. These statements are incompatible. So where does that leave us? So I want to argue that the equity-efficiency trade-off is real, but maybe a little less consequential than meets the eye. I want to also explore the ethical implications of adopting cheaper but less effective interventions. And I hope also, maybe a fond hope, to persuade you that cost-effectiveness analysis is usually a sound guide to global health resource allocation decisions. So let's step back and talk a little bit about cost-effectiveness analysis. So we have a grid here. This represents the whole possible terrain of cost-effectiveness outcomes, and as you can see, I've divided it into geographical quadrants. Let's talk about so cost, it goes from lower cost to higher cost on the vertical axis, effectiveness, lower to higher effectiveness on the horizontal axis. And let's talk first about the northwest quadrant. And here we have an intervention that is both more costly and less effective than the referent intervention represented by the yellow dot at the origin. So what could you say about such an intervention? One of the things that I might say is, who cares? There's no trade-off. It's less effective and less costly and should be discarded from further consideration. So let's look at the southeast quadrant. Here we have interventions that are more effective and also less costly. So I would call these no-brainers. They should be implemented. Again, they require no further analysis. Once this has been established, they should be adopted. Now let's go to the northeast quadrant. This is where most of the action is, because here we have real trade-offs. We have interventions that are both more effective but also more costly, and the question is, is the extra cost justified by the extra benefit? But we don't talk much about the southwest quadrant. So here we have interventions that are less costly, but also less effective. So why don't we talk about it? Well, the logic of cost effectiveness in the southwest quadrant exactly mirrors the logic of the benefit in the northeast quadrant. In the northeast, the question is the additional benefit worth the additional money? And in the southwest, the question is, do the opportunities made available by the cost savings justify the immediate foregone health benefits? So these are mirror opposite, they're kind of symmetrical. And in the context of building portfolios for universal health care, does it make sense to spend more time looking for options in the Southwest? And I'm suggesting that it does. So I want to step back a little bit from this inquiry. We'll return to it and ask a more general question about how can you tell if something is cost effective? You have a cost effectiveness ratio, but does that mean the program should be adopted on economic terms? What do we mean by cost effectiveness? Well, until recently, the answer was provided by WHO and the WHO choice model and was widely accepted, which is to say that the definition of a cost-effective intervention is one in which the cost per DALY averted is 3 times the annual cost of GDP in the developing country. That would constitute cost effectiveness, or if it was less than 1% or 1 time or less than the annual GDP per capita, it was deemed highly cost effective. So this is straightforward. These are easy calculations to make, simple, direct, kind of intuitive. So what's wrong with the problem with the WHO threshold? So how much time do you have? There's lots that's wrong with it, but I'm going to confine my remarks primarily to the first 2. One is that it doesn't take budgets into account. So we're in sort of this Alice in Wonderland world where anything that's deemed cost-effective, it's sort of implied that it should be funded. A second difficulty is, and I'm going to exaggerate a little but not much, is that any global health intervention which is found to be effective will almost certainly be cost-effective by WHO standards. The threshold is just too low. So if you can't eliminate programs, if everything is cost-effective, that leaves the decision maker with very little help. The result is that cost-effectiveness analyses have been less useful than they otherwise would have been, and when the WHO threshold is used, it often results in misleading conclusions. So here's an alternative way of thinking about what is cost-effective and what is cost-effectiveness threshold. I have borrowed the bookshelf analogy from Anthony Collier at the University of York. So in this analogy, each book represents a program or an activity. The vertical axis represents cost-effectiveness. Taller books are better. That is to say, they have higher cost effectiveness. The horizontal axis represents expenditures. The width of each book represents the cost of that program. And in this highly rational world, interventions are ranked from most cost effective to increasingly descending levels of cost effectiveness until you hit the budget limit. Then you've run out of money. Anything to the right would not be included in a program, such as a universal health care coverage program, and anything to the left would be. So what happens when a cost-effective intervention is now available and you want to consider it for introduction into the plan? So this intervention A is more cost-effective than the interventions to the right of that big red arrow, but to the left of the budget limit. So it's competitive here, but remember, if the budget limit is real, that bookcase on the left side is now getting crowded, and we're going to have to make room for this new intervention, and we could do so by moving intervention B, which was formerly in the program, out to make room. This is painful. It's painful for decision makers and policy makers who don't like to take things away from their constituents, and it may be painful for the beneficiaries of Program B, who may now be deprived of some health benefit that they value. So how does this work? When you introduce a new option in the southwest quadrant, we're gonna label the new option A, and B is just outside the budget. We can decompose A into 2 components, or 2 variants of A more cost-effective and a less cost-effective. So think, for example, of a generic screening and treatment program that provides behavioral counseling on an individual basis. That's A. A prime is providing the counseling component on a group basis. So it's now more cost-effective, not necessarily more effective, more cost-effective and cheaper. And A represents the incremental cost-effectiveness of individual counseling as compared with group counseling. So now B looks like this. It's more cost-effective than A prime. So by strictly cost-effectiveness criteria, you would remove A from the portfolio. This is painful. It's exactly the same mirrored pain as what happens when you introduce a more cost-effective option in the northeast corner. But you get additional health benefit, which is the entire point. So now we have A prime, which is group counseling, comfortably within the budget, and B, which formerly had been outside the budget, is now in for a net increase in health benefit. So there's a problem of incentives here. Who wants to develop and market interventions that are less effective than existing feasible options? The next slide shows an ad that is currently running, not in our universe, but in a parallel universe. So this might look in our universe like an ad for Lipitor, but it's not. It's actually in the parallel universe an ad for Lipitor cost effective. And here's the pitch. Only 8% more heart attacks than the other leading statins and 53% cheaper. Sounds good, right? So in our universe, pharma and medical device companies are not incentivized to develop options in the southwest corner. It may be possible to change those incentives, but in the meanwhile, we're not so constrained. We can pick options in the southwest corner that are based on reconfiguring interventions that already exist. And I list a bunch here, and it could be a much longer list. But for example, Stavudine versus tenofovir for ART for HIV. Stavudine is much cheaper, $60 per patient year versus $150. That's big, but you sacrifice the more attractive adverse event profile of tenofovir. Less frequent versus more frequent screening, etc. I'm not saying that any of these are cost effective or should be chosen. I'm saying these are the kinds of considerations that you might make when looking for opportunities in the southwest quadrant. So here's some reasons for staying out of the southwest quadrant. Some are, I don't know, kind of psychological or emotional. It insults our commitment to progress, to advocate for the introduction of a less effective intervention. That's not our idea of progress. We want more effective interventions. And there's also discomfort with explicitly choosing lower quality interventions for people who have little access to health care or who may be impoverished. There's also a sort of political or economic argument that this entire supposed trade-off is false. There's enough money in the world to provide everybody with the more effective option. So this is all kind of a false issue. There are also equity considerations. Why should those who have less access to health care continue to receive technically or qualitatively inferior options? And then there's the problem of incumbency. Those currently receiving expensive treatment are entitled to continue receiving it. So which of these concerns should affect policy and portfolio decisions? I say that none of them should. So I think I can dispose of the psychological or emotional arguments pretty easily. I'm not saying they're not compelling. I'm not saying they don't have force. I'm saying they have no role in resource allocation decisions where the idea is to optimize health, is maximize health given the budget constraints. So I say to those emotional feelings and even the discomfort in providing lower quality options in resource poor settings, I say, so what? This isn't about feelings. It's not about feeling good. It's about doing good. Regarding the political and economic argument that the trade-off is false, there's enough money to do everything, this is true. But only in the abstract. In the real world, budgets are constrained, trade-offs are real, choices are consequential. And I would add that the golden era of rapid increases in global health funding is over, has been over for a while, and we are in the era of looking to do more with less. That's where we are. So what about the ethical concerns? So, again, why should those who have less access to health care continue to receive inferior options? What this question ignores is the foregone health benefit of all the people who would have benefited had the cheaper, albeit less effective, intervention been available. Those currently receiving expensive treatments are entitled to continue treating it. Problem of incumbency, it's a sticky one, like depriving people of services that they exist. I don't think I'm underestimating the difficulty of doing that, but I would argue that global health actors have to weigh population needs, not only the needs of current beneficiaries. That's what we mean by public health. That's what we mean by the global in global health. So is efficiency the only criterion for portfolio construction? No, of course it's not. But we need to be clear that deviation from the cost-effective optimal in favor of pursuing other ethical concerns by definition means foregoing health benefits. So pursuit of those goals may be justified, but the trade-off is real, and simply invoking equity or human rights should not shut down analysis. In many cases, it's possible to quantify the trade-off. The trade-off should be confronted before a final decision is made. Thank you.
Thank you very much. Two great presentations, slightly different tack. I'm going to take the moderator's prerogative and ask the first question. And if you raise your hand if you want to ask a question. We have two interns with microphones who will walk to you, and in a moment you'll have the chance to ask that question. I'm going to direct the first question to Dr. Goosby. In today's environment of shrinking resources for global health, seems to be the case. You can question my premise if you want. But if that is the case, how much weight does Elliot's argument have that we should be willing to look for Southwest Quadrant options that are a little bit less effective, a lot less cheaper, and thereby free up funds for other high-priority strategies? Is that compatible with global health diplomacy?
It is. I think that it's the reality, whether you think it's fair or not, it is the reality that you're confronted with. I love the way you stratified it depends on where you sit in the delivery of a new treatment, a new diagnostic to a delivery system, incorporating in the old delivery system, but it depends on where you are in that system as to how you position with your advocacy or defense. The person over the doctor-patient relationship level, where decisions are made about the tenofovir versus the D4T, those are real life-changing peripheral neuropathy, level of wanting to commit suicide type of peripheral neuropathy problems. Getting that drug out of Africa was huge, yep. And it was largely driven by the unacceptability of that side effect. Mm-hmm. And the costs we were able to manipulate by moving to a generic manufacturer and getting the manufacturer of tenofovir to work with that generic manufacturer to make an excellent molecule. Yep. But it was a whole lot of goodwill and a whole lot of philanthropic thinking went into that. The costs went down to a fraction of what it was, yep. And enabled it to be pulled back. But so I guess I would say it's a blending of both. You've got to take the realities and work with them, but not forget the role of advocacy and the right-wrong of it. Your point that there is enough money to do this, if we look at it differently, needs to still be on the plate. That argument needs to come from you guys, if I could say it that bluntly, because you are in a kind of honest broker position, whereas everyone else gets tainted as soon as they go to their corners. Mm-hmm. But I think it's the conversation that we need to have as a global society. Yeah. I mean,
one of the criticisms I have about my view, or the sort of view of cost effectiveness analysts in general, and I think it was implied in your comments, is it's like we've got a model and we're looking at stavridine, we're looking at tenofovir, and the prices are fixed as far as we're concerned. They are what we are. We accept them. We plug them in the model. And I'm saying by hypothesis that stavridine is more cost effective. I actually don't know that. I mean, there was a lot of debate, and there was also sort of interim proposals that people would start on cheaper stavridine, but then as those that suffered severe side effects. Yeah, so there's all kinds of possibilities. But the point I want to make is a problem with cost-effective analysts sometimes is we treat the world as sort of given and fixed, whereas diplomats or politicians are trying to get the price down, advocate, mobilize political support for something that wasn't cost effective, let's say, but becomes more cost effective. And beyond whether it's cost effective or not, and again, this is the point you made earlier, if it's not politically accepted, if it's not acceptable, it doesn't really matter how technically optimal it is. So I'm sort of backing a little bit away from what I presented as sort of a hardline kind of technocratic position. But at the same time, there is the technical optimal. And a question I have for you is how you see your role in helping to move unpopular decisions which now may be outside the acceptable political discourse inside it. How do you sell unpopular programs where, for example, restricted benefits to identified lives, which politicians love, to broader, larger benefits to statistical lives that, I think you get.
Yeah. No, I think you bring up all the right points. It's a dilemma, but there has to be an awareness of the complexity of it and a willingness to protect. And I think it comes from those who are most knowledgeable in the system and those who are looking at the cost-effective, constructing the cost-effective arguments, also are dependent on at some point, somebody, some entity describing what's the best science, regardless of costs. That has got to be on the table as to this WHO, who does not do this, should have, with the analysis of the science, said these are the drugs that we believe are in the best interest of the patient. Mm-hmm. And they have a variety of cost constraints and logistics that preclude their ability to be acquired, but that scientific definition of what is the correct standard of care needs to start the conversation. Each country then can look at what it can or cannot afford, and the global community needs to look at what are they willing to share that responsibility of acquiring that new diagnostic or treatment commodity. Is there a willingness to help countries that can't afford it? Yeah. And that's a different discussion. So I kind of cop out from your challenge by saying you're not going to solve it, but what you are going to do is make sure that there's clarity in what the discussion is, what the options are, what the consequences of those options are, and now what can we invest in?
So in this rational world, which perspective should the cost-effectiveness analysis have? If we are, in the hard way that you presented it, looking at the budget only, would that be the programmatic perspective? But there's possibly also a valid argument that if you are going to be so strict about it, that it could be the societal perspective for the cost-effectiveness analysis. So when you're drawing that line, and you have that budget, the budget is presumably a programmatic budget. So, for example, the Ministry of Health. But the resources that are involved in attaining those health benefits are not only the resources for the Ministry of Health, but they're also client and family resources. Yes. So do you have any comments about the perspective of the cost-effectiveness analysis? Yeah,
so I'm all for the societal perspective whenever possible, and that's sort of the current state of recommendations. I can't see for most analyses why you would exclude sort of broader indirect effects and productivity effects and so on. But in the end, the budget for the program is still, so that's on the side of the healthcare system. So I'm not sure that the results change if you look at benefits broadly or narrow it. I mean, the number, the height of the books in the bookcase and which ones fall on which side of the budget line will change depending on how you account for benefits. But I'm not sure it presents a particular conceptual departure.
Yes, hi. My name is Julia Walsh. I'm from the University of California at Berkeley. And I've been an advocate, along with several other people, for many years on selecting those interventions which are most cost-effective and providing them to the largest proportion of the population that would benefit as possible. There is a huge constituency to expand and expand and expand. So I would like some examples of where it has really worked for a very long time, and what were the political and social determinants that allowed that to happen?
Well, I think there's a large number of global health interventions that are highly cost-effective. I'm thinking of things like malaria bed nets, childhood vaccinations, safe motherhood programs, water supply and sanitation, and that I think that their demonstrated cost-effectiveness has been an important part of their sustained funding. That's my strong sense. So while cost-effectiveness analysis is not used in as many decisions as I would like, I think it's a mistake to say, well, nobody pays attention to these technical considerations.
Cost-effective is in most every large decision that I've been engaged in at government level, but it is by no means the only decision. But it often starts the discussion, informs the discussion. But I would say it wanes in its use in most of those discussions. A decision is made, and then where I think there is again utility for a cost-effective analysis to continue, it doesn't. And so in looking at year 3, year 5, year 7, as costs change, is the cost effectiveness the same calculation still? And what is the obligation of that analysis to remain true over time? And for issues that are ongoing decisions, it's a budgetary decision every year. That fight is re-engaged every year. So to me, I think looking at the where you have strategic utility kind of unrealized with a cost-effective analysis is in that tail.
Hey, I'm Tyler. I'm an anesthesiologist at UCSF and work at San Francisco General Division of Global Health Equity. My question is for both of the panelists. Dr. Goosby, you talked about the importance of framing things in the terms, health diplomacy terms of what outcomes you can buy, and especially when talking with policymakers. So I'm an anesthesiologist, and I often struggle with this issue of what is the outcome we're buying with anesthesia. Patient goes to sleep, patient wakes up, and how do you disentangle that from the outcomes of surgery itself? And I'm sure there are other elements, cornerstone elements of the healthcare systems, which are critical in the function overall, but difficult to apply in cost-effectiveness disease DALI terms. And do you think that it's A, necessary that we must frame it in those terms? B, is there some other way of framing these things in a funding decision? Yeah, I guess those two options. How would you approach this sort of issue?
I'll take a quick stab at that. I think it's important that in developed settings like the United States, that the appreciation and unpacking of the contribution that anesthesia makes to a gallbladder removal is part of the analysis. That is still going to be important. Maybe it's going to become even more important that there is an understanding in an academic sense of what are the contributors to that outcome of the removal of the gallbladder successfully, the person going home without an infection, et cetera. But I think bundling is what I hear people talking about. And this is in the insurance, community jargon, but I keep hearing bundling. So I'm worried you might get thrown into a bundle for surgical procedure.
Let's give a big round of applause for Drs. Marseille and Goosby. Thank you.